I need to pull up my notes here. This is a survey that was prepared by partly by DISHES and partly by the Texas Cardiovascular Disease Stroke Program. GETAC had some input on there, as well as the Office of Surveillance, Evaluation, and Research, also DISHES. This was a survey that was put out. It was a survey monkey that was sent to the leadership with all the RACs, and not surprisingly, because there was some funding associated with it, we had 100% participation by all the RACs. We didn't have all data points completed, but the vast majority of the data set was complete. There was also some sort of cleaning of the data, some reconciliation of unusual data points. So overall, there are 22 RACs that reported data, and within the 22 RACs, one RAC did not report the number of hospitals that they have, but overall there was 342 licensed hospitals, and I'm not sure exactly how many of those are PCI centers. Looking at the capabilities of the individual RACs, 3 RACs don't have any type of either administrative or data analysis personnel. And then you can see the breakdown. Roughly half of the RACs have both data and administrative support, and then the other half has one or the other. If we look at the percentage of EMS agencies that have at least half of their systems have ALS trained personnel, roughly 2/3 of the RACs have 80% or more of their EMS agencies have ALS personnel. But even in those agencies that have a sort of a smaller pool of ALS personnel, they do have still a very high number. Roughly 60% of agencies have 99% of their EMS, or 60% of the RACs have 99% of the EMS systems have 12 lead capabilities. And then if we look at the percentage of EMS agencies that can perform pre-hospital cath lab activation, Dr. Hiller mentioned earlier about the reduction in reperfusion time with pre-activation. We see that again, just about half of our RACs have a very high percentage of EMS agencies that are able to perform cath lab activation. Again, I don't have enough access to the granular data to be able to find out how many of these EMS agencies are able to pre-activate the referral centers. So can they pre-alert the referral centers in order to facilitate the door-to-drug time for thrombolysis? And then do the hospitals provide STEMI outcomes back to the EMS providers? Most of the RACs have some mechanism to get some information back to the hospitals. There are really only 3 RACs that have no mechanism to get any data back to the providers, and the two other RACs that don't know. My guess is if they don't know, they probably don't have some sort of mechanism. And that's the report.
So David, one of the purposes of this survey was to perform a gap analysis in terms of if one were thinking about ways to help the RACs perform better. So the so-called gap analysis. So can you summarize the high points of the gap analysis?
So it seems like we have most of our agencies have either ALS personnel and or 12-lead capabilities. What seems to be the largest deficit is the rack infrastructure to be able to pool EMS data, correlate that with hospital outcomes, and be able to provide that feedback to both EMS systems and back into the emergency departments to be able to share those practices.
So if they have 12 leads, what percentage of them can actually transmit the 12 lead? If I remember correctly, previously our information was that a sizable minority could not transmit.
I think the question, if I remember it, it was either they transmitted or they accepted pre-hospital notification, right? So it allowed for both responses in that question. I'm sorry. Is that? I think I remember when we answered the survey said either one, you have to transmit, or two, you have to do pre-hospital notification. So the question itself allowed for either. I don't think it broke, I didn't break it down in mine.
So the other limitation to at least the data set that I got back was it is a function of the EMS agency. It is not a function of the number of EMS runs. So an EMS agency, at least in my area, is San Antonio Fire Department and Utopia EMS. There's a remarkable difference in the number, the N for both of those systems. And so San Antonio Fire Department probably has close to 100% EKG acquisition. The transmission piece is not as clear, but they do pre-activate. So from the results that I got, I wasn't able to identify to tease those data out.
Catherine, go ahead. Don't mumble. Don't mumble.
She said that makes sense.
Okay. So many people have 12 leads, and they either make the call or transmit. Is that what you're saying? Because there's a question about the allocation of resources and support of activities. And if there's only a handful of agencies that need 12 leads, and say they would use them if they had them, that's important to know. Or if there's hundreds of them, then that's another issue. Do we have any information on that?
So what I don't know is who are the agencies that don't have them? Are they EMS agencies that have a single ambulance, one paramedic, and 4 EMTs, or are they the EMS agencies that have 6 or 7? My instinct, and I don't have the data to support this, is that the larger EMS systems are going to have those resources in place. It's going to be the smaller agencies, and I don't have the granularity to be able to identify that.
Yeah, and the other issues that have been bandied about in the past is in the areas that don't have ACLS rigs, but then still respond for chest pain, can they carry the 12 lead and use it responsibly and so forth? How many of those areas exist?
There are a number of BLS programs that are able to acquire and transmit 12 leads that don't have the ability, or don't have the education or experience to be able to interpret those. So, I mean, there is still that need. I mean, if we have agencies that are responding to chest pain patients that don't have a mechanism to acquire or transmit, they need one or the other. Either be able to acquire the 12 lead and transmit, or to have the trained personnel to be able to interpret and make the call from the field.
So there seems to be a public commenter that would like to speak.
Thank you, Dr. Smalling. So Eric Eppett from Strack. So I think it's multifactorial. It's a complex issue. So first is, how many are ALS or BLS, or MICU and BLS? So let's say there's BLS agencies that might need a 12 lead that could transmit it. So I agree with David that probably the number is small. Probably the number of agencies that would need that are small, and the number of agencies that need that would have small numbers of trucks. That's just all. I think that's accurate. Then the next problem is, once they have a 12 lead, can they transmit it? So that requires wireless technology in the truck. So now we have purchases, not only of the 12 lead, we have purchase of a wireless gateway is what it's called. So it turns Wi-Fi, it's like a hotspot that you carry in your bag, except it's made for a truck, and it's about $2,500, give or take. There's some cheaper ones, but the InMotion is usually the most common. It's about $2,500 installed. Then you have a monthly service fee, like a wireless card, right? It's just like your wireless card. You got to pay 20, 25, 35, 45 bucks a month to have that wireless, just like your phone. Then we have the next problem is, if you try to figure out who these agencies really are, and Utopia EMS would be a good example. If you guys have ever been to Garner State Park, that's kind of on the way. You're out Highway 90 from San Antonio, about 95 miles. You take a right and drive another 30 miles, and voila, you're in the middle of Real County. And I'm going to tell you, you can have the coolest 12-lead machine and the greatest in-motion gateway that will give you wireless signal if only a wireless signal existed. Right? So we may be shooting for 100% of having EKGs, having the right 12-lead machines and the wireless technology on board and the capabilities, and we're going to go to a place that doesn't have wireless signal. I have some anxiety about that. But all of those factors need to be in place. And if the hospitals in that area, I was just talking to Ryan about this at lunch, and if the hospitals in that area are already agreed to do pre-hospital notification without the 12 lead anyway, if they're activating their cath lab based on the paramedics looking at the 12 lead, so maybe get the 12 lead box for them is good enough if they're an ALS and can interpret it, and then say we're activating the heart alert or whatever they're doing, right? So some perspective with this
Eric,
issue.
wait, step away. So all
Yes,
these
sir.
things cost money. So the device costs probably the largest chunk of money.
Right,
Beyond
25,
that,
30 grand.
You can buy 25 to 30 grand for the device, for the 12 lead acquisition device. And then you're talking another 2,500 for the Wi-Fi interface. Or you then have to spend money on training your people on how to interpret the 12 lead, unless you just want them to read the computer interpretation.
Right.
In my experience with most cardiologists, they're not satisfied with that computer interpretation. They are much more happy to have people. But so in the end, it winds up coming both not only to the technological impasses, but also the financial impasses. And for these small one provider in rural Texas, a lot of these places are just looking to get new tires for the next year. And so
Yep.
We need to start thinking about funding. And the state offers the local projects grant, but they are pretty much consumed with people getting an ambulance replaced and these things. So we may need a benefactor to help out in some of these low volume remote areas.
If the Heart Attack Coalition or other efforts does go pursue funding for equipment, that there are new questions that will have to be resolved, which is who's going to approve those requests. So as a non-911 private provider who mainly does dialysis transports but isn't licensed EMS provider, are they eligible? Do you have to be do you have to have a 911 contract at least to be eligible for the funds or not? Who's going to approve those, kind of like the local projects grants? What's the long term, when from 5 years or 7 years from now when they need to be replaced? Is that funding going to be there again, or is this one-time equipment funding, a one-time shot from the legislature? Those are all decent questions. And if you do the wireless, oddly, if you told Utopia MS, the biggest question they would have is who's going to pay? Great, all the equipment, send it to me. Who's going to pay the wireless bill? Because literally, we may be having bake sales just to put backboards or to put gas in the truck. We have volunteer EMS guys. I'm saying them because I'm representing Anywhere, Texas, that's in the rural environment that has volunteer EMS. Those are genuine questions. You'd hate to see a $30,000 monitor and a $2,500 wireless thing, and it can't go because they don't have the money to pay for the service.
I think we have to go for the numbers, so.
I got a comment. Greg Fonero at UCLA, they had this problem in Los Angeles, and Greg said they cured it with this. That's their wireless. They just took their iPhone out, took a picture, sent it to the hospital. The Pulsar system that's been developed in Longview and is going nationally, they found that the paramedics just take a picture with their iPhone and transmit it to the hospital. If you can't use the iPhone, then you gotta trust your paramedics and their training.
Another
Well,
solution.
so I also see that,
Lonnie?
Just another solution that we just implemented in Wyoming was cell boosters. I'm wondering if, like Neil or anybody in the room has had experience with
With what?
utilizing cell boosters. Is anybody in Texas doing
So
that?
Cell boosters that's a Wilson, like the Wilson cell booster. Yeah, well, an InMotion is a 3-watt externally driven cell booster, if you will, in the first
Yeah.
place. So the InMotion, that's why it's $2,500 because it has an
Right.
external antenna, 3-watt transmitting capability from the radio out to the cell tower. So you're getting that capability. That's what an InMotion does, as opposed to a small hotspot that's $69 at Verizon.
Yeah,
So I
we
think-
have some services that use that in our area, and the reality is, if you're still far enough from a cell phone tower, it doesn't matter how much power that thing's putting out, you're not going to get the signal.
Okay, I don't think we're gonna solve that particular problem. We've got a lot of bigger fish to fry than Utopia.
so the other piece of this is that having the technology and the training is great, but having that information still has to drive a decision. So if identifying the pre-hospital STEMI, if you're so far away from a PCI center that it doesn't matter, you're not going to be taking them to, you can't drive them or fly them to a PCI center in a timely enough manner. They need to be thrombolized, so they're going to go to a local facility anyways. So I think the areas that we need to really sort of focus on are those transitional areas where they're having to make a decision based on that information, whether they are going to drive the patient, bypass a local facility, drive the patient in, or if they're having to decide, am I going to call a helicopter to fly this patient out as well?
Okay. All right, now that we've solved that problem, Dr. Rutledge is here to talk about the potential for greater interaction with the GETAC Cardiac Care Committee and DISH's Cardiovascular Disease and Stroke Council.
Thank you. For those of you guys who don't know, the Texas Council of Cardiovascular Disease and Stroke was enacted by the 76th legislature, so it's been around quite a while. And we're charged with developing an effective and resource-efficient plan to reduce morbidity, mortality, and the economic burden of cardiovascular disease and stroke for the state. We make a written recommendation to the legislature each biennium in that regards, and submit legislation and or comment on pending legislation that affects anyone with cardiovascular disease and stroke. The last session we received the Rider 97 money, and with that money we've gone forward with trying to develop a gap analysis for the state. And the information that you guys just saw is the very first iteration, the very preliminary part of this. And it's difficult to do. And the data that you've seen is just sort of the tip of the iceberg. We've really sort of gone about trying to approach this from two ways. One is a RAC-centric approach to sort of get an overview of the whole state from the EMS standpoint, and the other is a hospital-centered approach, which you haven't seen yet. That data is about to come out. We've contracted with the DSHS to provide this service for us, and one of the issues that we wanted to be extremely sensitive to was not just PHI, but hospital identity data. And so the information that we want to give back to your committee, to GETAC, and to the Congress is really sort of an overview of the state without pointing our finger at any specific person. And so in some regards, that's why the data is not as granular as you would like yet, but I think it's going to be more granular because the next step is to show it on more of a TSA or RAC level as we move forward with the new data that we're putting together. We have opportunities to do more data, and with the next round that we're going to do this next year. Currently, Dr. Wozniak represents your committee at the council level. Dr. Hillert here is the governor's appointee to the council. The council is like GETAC. It's governor-appointed positions. There's people like from DAR, people from DSHS, there's lay persons, there's cardiologists, stroke. Each individual person is designated by the governor. If you guys go forward, and I hope you do, with legislation to work on a state transport plan for STEMI, one of the things that we did with stroke is that we required or asked for a person on the Texas Council of Cardiovascular Disease and Stroke to represent that. And I think this committee should have that an official position, a voting position, rather than just a representational person. But it's not something that we can do ourselves.
So that should be, if a volunteer organization or perhaps legislature, you would suggest that that would be one of the requirements of the bill.
Yes, and it was what was done for stroke. It would then give you a voting seat on the committee. But in the meantime, we have Wozniak that represents you and comes to each of these meetings, and you have Dr. Hillert, who is the representation for heart disease.
Wozniak is a voting member?
No, he is not, and I can't make him a voting member. But I can, what I've also done is the council has designated people to counsel us in regards to the next data initiative and how to formulate the data. Wozniak is your representation for that. And some of the questions that you're asking right now for the next monkey survey for the RACs, I think, or I would request that you guys, through Wozniak, come up with questions that we can work on to sort of answer the questions that have come up to do that further gap analysis. So what's the background or what's the reason to do a gap analysis? Well, the reason to do a gap analysis is to let the legislature know where resources need to go. And the reason they need to know where resources need to go is because there's resources coming out of our back pocket for Medicaid dollars to spend to take care of these issues. The other thing is, once we have a gap analysis and we see where resources are needed, we're going to need people to then allocate that money. And I think this would be a good committee to then look at not just 12 leads or the transmission, but what other equipment and things need to be given. And traditionally, a lot of times we've done stuff in a generalized rack. We give every rack, every rack gets $50,000 or something like that. I don't think we're going to have the resources to do that, and I think your committee is the committee that would be a good place to help determine how we allocate funds if we can get those funds. So, to summarize, our council is here to help represent you. We very much want your participation. You have Dr. Wozniak as a representation right now to the committee, but non-voting for your committee. And then for the state, Dr. Hillert represents heart disease. And that's what I can think of right now. What questions do you guys have?
One of the issues that we talked about extensively in the heart attack consortium was the bringing in of more people to the data oversight and analysis that have national presence, for instance, like people that or on the ACC database committee, which would interface with both our group and your group, which seems to be a reasonable distributive approach to really drill down and get a number of fronts working on potential solutions. Does that sound like a reasonable suggestion?
We would certainly love to hear if you have some additional people you would like to have as to provide us with recommendations. We'd certainly be amenable to that.
Okay, great.
So we talked just before about funding issues needed for some rural areas, and there's funding issues needed for data collection, and there's funding issues for other things. And is that something that your group would be able to represent to larger governmental and non-governmental entities to stimulate funding? We're limited with what we can do as part of the government. We really can't go do that. So we need to be careful about how we behave. And so I'm sure that because there's a lot of, as you point out, there's a lot of overlapping interest. But I'm wondering if you're able to do some things that we can't do.
Yes, we can recommend legislation. And in our legislative report, we are making recommendations on preventative care, acute care, and then chronic care remediation. Part of that in our preliminary recommendations is specifically to fund the RACs organizationally, and to do a 12-lead EKG fund. And then it is my preference and our recommendation that the best way to do that is through probably this committee at the GETAC level to actually go about dividing who and where that goes based on the gap analysis that we can do. So yes, that is our plan, and that is in progress. The question is, will we get any money? And I don't know. Great, and you can send the money, P.O. Box.
Thank you very much, Neil.
You're
Appreciate it. I will add that Dr. Rutledge has been very, very helpful on the Texas Heart Attack Consortium, giving it sage advice after having shepherded the stroke bill through the legislative process. One of the things that I've been tasked with by Dr. Greenberg is revising the strategic plan for the Texas EMS and trauma system. So this was in the era before there was a stroke committee and a cardiac care committee. And so we have to come up with recommendations to the council of GETAC that we would like to see considered. It would appear that acute emergency health care is a little more comprehensive than trauma. And so as we go forward with dealing with issues that account for more than 60% of the mortality in Texas, when trauma I think is 10%, would be reasonable to consider renaming this entity to something on the order of Texas EMS Emergency Healthcare System. So would the committee like to consider that as a recommendation to the GETAC Council?
So we've been asked to go through the entire document, right?
Yes.
Yeah, I would actually consider taking, with your recommendation, just make it the emergency healthcare system. EMS is part of the overall emergency healthcare system. It's not EMS and the emergency healthcare system. It should all be comprehensive under one title, I would suspect.
So the Texas Emergency Healthcare System. So that's the motion.
And I'm coming from the EMS end, so
I understand. Any discussion regarding this? All in favor?
Right.
Any opposed? So Catherine Bissell has generously agreed to represent us to the council and give our report. So we need you to make a motion to the council regarding this potential renaming of this report, the strategic plan, and then the cardiac care committee would be happy to provide revisions appropriate for that. So what I'll do is I'll circulate this 2002 plan to the committee. You all can pick out areas that you would like to focus in on, and we each will have a go at certain sections and then synthesize that for Dr. Greenberg and his associates. Any other comments? Any more public comments? Professor Epley in the back, you have receded. It's unusual for you to sit on the back row and stay there. I was just curious if you want to make one more final shot.
Yes, sir. I just want to thank Mr. Epley for dressing up for the cardiac committee as compared to how he was dressed at the EMS committee.
After I knocked out those 8 miles, I thought I should take a quick shower and get back.
All right, it says we have 10 minutes left. If it's okay, we'll adjourn early. And I want to thank Dr. Person and Karen Pickard for providing their excellent participation through the years, and we look forward for them to hearing from them on a frequent basis. And we trust you will represent as Karen at the council level. Thank you so much. I'll adjourn. Happy Thanksgiving.
Yeah.